So another patient is an 83 years old lady presented with biliary obstruction, subsequently diagnosed with metastatic CA ampulla early this year. So we've done a ERCP previously with a metallic stent inserted on February. So the patient was remitted again recently for gastric outlet obstructions, with CT done showing irregular mural thickening at D2 with significant narrowing and upstream dilatation. And the liver function was normal. We have done an OGD and with feeding tube inserted for nutritions. We have discussed with family and about duodenal stents versus US guided gastroenterostomy, and they are keen for US guided gastroenterostomy. So here's the CT showing the tumor. So let's go for the US guided gastroenterostomy.
Can you hear me?
Yes, we can hear you.
Okay, so I have Sangso with me and our very capable nurses here helping us all 3 days. So a big thank you to all the nurses. Do you have the endoscopic view?
Yeah, we are seeing.
So you can see a lot of food. I tried to remove some, but it was difficult because there was grapes and vegetables and all sorts of stuff. And then I had to cannulate the stricture blindly. I shouldn't have stepped on that, but there was a stricture at the, you can see some contrast, hold up at the metal stent level. So there was a stricture around 2 to 3 centimeters at that level. So I couldn't really see that stricture just now. So I had to do some blind probing. At one stage, the guide wire went through the biliary stent. Eventually, I was able to cannulate away from the stent and have a guide wire inserted all the way to the jejunum. And my endoscope there is a over tube. So I'm going to pull out my scope now. Okay, so my nurse is holding on the over tube. And I'm pulling on the scope. Okay, so the over tube is to help me insert a double balloon occluder, which will help distend a bit of small bowel to allow us to see it by EUS. So the aim of this procedure is to create an anastomosis between the stomach and the D3-4 level. So the device, the double balloon occluder, it's here. So can you see it? External view. Okay, so there are 2 markings. These 2 are the balloons. And there is a area where you can inject water into the 2 balloons. So when it's inflated, it will occlude a bit of small bowel, the duodenum, in between. And we can inject saline through these side holes to distend the small bowel in between. So this creates a very distended small bowel and allows us to see this by US guidance. So it's a very safe, stable platform. So anyone could do it, almost. And we're going to be inserting a 20 millimeter hot axios. So the hot axios comes in 15 usually. But recently, they have a new update of a 20 millimeter in size. So it's almost equal to a duodenal stent.
Is there any case that you encountered that you cannot pass this tube beyond the tumor obstruction site?
So far, not yet. This tube is a nasogastric tube. It's you open the open the this size is 12 French, so it's very small. Can we have a lot of gel? And the tip, you can see the ball coming out down. It's very easy to navigate the stricture. So you can see the over tube really helps because it prevents the tube from looping inside the stomach. As you can see, it's going out very well. There are two okay, so Philip, you have a good prediction?
No. I just ask in out of my curiosity.
So this stricture is tight. We might have to dilate it.
Yeah.
You should have reminded me just now.
So, but I guess in this case, it's such a tight stricture. Even if you want to put in a duodenal stent, it might also get caught.
Yeah.
Of course.
So may not be that different in
Yeah.
that sense.
Well, we'll
Anthony-
give it some try.
Yeah.
Okay.
Okay.
Yeah, pass through.
Very
Excellent.
nice. Lucky.
Excellent.
So Anthony, how would you compare this technique with traditional duodenal stenting?
Well, I think, to be very honest, duodenal stent is more of a basic procedure. Our trainees can do it. It's very cheap, relatively cheap, and it's effective. So it's a good procedure, and it can be easily done without much complication. But of course, if you have the GJ, then it's a little bit different because the reintervention rate might be lower, and hopefully with duodenal stent, you have uncovered duodenal stent, so the risk of tumor ingrowth is higher. So I think with this device, because GJ can be done relatively simple and the risk of complications is lower, so I think only with a very dedicated device that GJ may become more popular. Okay, so we're going to inflate the balloons. Contrast. Okay.
So Anthony, we'll go back to you shortly. So we'll go to room 1 to see Rob's case first.
GJ. So
Hi,
Hello.
Anthony.
So if you can see my US view, my small bowel is quite distended.
Can we have the
my
US
scope-
view enlarged, please?
My scope is at the duodenal angle. I plan to insert the stent around the DJ flexure. You can see this shoulder bowel is straight. And you can see the two balloons occluding that bit of small bowel. It's not the best distension, I have to say. And I'm asking Siu-Feng to inject a bit more saline into the small bowel. You can see water going inside. There's some movement. Okay?
Yes.
And I think this is probably the best we could get for now. So the hot axios is going to be coming out from here.
So where in the stomach are you going to choose to the DJ?
So
position?
usually at the greater curvature, just at this area. Before we puncture, we will measure the distance. So this needs to be less than 1 centimeter. All right. So okay. So if everything's good, then we're going to go. Okay. So the axios is already inside the small bowel. I'm going to lock. And I'm going to deploy the distal French.
Okay. Yes, we can see.
So you can see
Deployment.
this distal French is in the small bowel. I'm going to pull back. Pull back until the flange is angulated. And I'm going to deploy within the channel. And I'm going to rotate and then push out the stent. And then that's the end of the procedure. You can see the indigo carmine coming out, and the stent in there, and that confirms my position. So with the device, it makes the procedure, which in the past would take us ages, but just then it just took us 2 minutes.
Very nice.
Very fast. Thank you.
So do you usually go by the endoluminal wheel to confirm the position, or you don't need that?
Well, we have indigo carmine coming out. So just now within the saline that we injected, we've mixed this.
Yes.
So I'm pretty sure we're in a small bowel. This is quite essential because in the past, people have punctured large bowel, creating a gastrocolic fistula and all sorts of stuff. So you don't really want that to happen.
So will you inject contrast at the end to confirm the flow into the?
We could. Can I have a ball tip? Okay, we need to deflate the balloons first.
When the patient can eat after
We will
procedure.
start them on fluid diet tomorrow. Yeah, and have low residue diet for deflate the balloons. Deflate. So I'm going to pass a ball tip catheter, and we can inject some contrast to make to show the passage. Okay. Deflate the balloons, please. Okay. So the balloons will take time to deflate. We can inject some contrast first. So what's happening is there's some food right here,
Yeah.
which we want to remove it because it's going to obstruct my stent later on. But this stent will generally open in around. So can you see the small bowel going down?
Yeah. We
Yep.
can see.
Yeah, so the stent will completely open around tomorrow. And because we have a balloon down there, so it's going to take some time to aspirate the balloon completely. So any questions?
Nice demonstration. Thank you very much.
Thank you.